Hey everybody, welcome to episode 352 of the Ortho Eval Pal podcast. I'm your host, Paul Marquis, and today we're going to be talking about rehab considerations after anterior cervical discectomy and fusion. Now, this is part 2 of a 2-part series. If you didn't watch last week's or listen to last week's podcast, you really should do that. We had an interview with Dr. Arredondo. It was awesome. We talk about the surgery and what to expect before and after surgery. So it's going to be good that you listen to that if you can first. All right. So today what we're going to be talking about is what patients should expect after an ACDF. We'll talk about post-op roadblocks, understanding what to do and not to do after surgery, and we're going to discuss treatment tips at different stages and so much more. But before we get going, I just want to talk about our sponsor, Rangemaster. Rangemaster has been in the business of helping patients for a long time. They carry multiple rehab tools and most recently added my favorite, the Sling Thing adapter. Now, the Sling Thing adapter is super easy to use and it brings immediate comfort to your sling wearing patients. If you are a medical provider or you work in the orthopedic field and you'd like to get a free sample, just click the link in the show notes or email jim@myrangemaster.com and put OrthoEvalPal in the subject line or as the coupon code, and they will send you a free Sling Thing adapter. You're going to love this thing. Your patients are going to love this thing. So here we are. We've had several comments since the last show talking about how excited people are for this show today. So, like I said, if you didn't listen to part 1 with our interview with Dr. Arredondo, neurosurgeon who does a lot of complex cervical spine surgery, you really want to do that first. I think that'll really piece everything together for what we're going to be talking about today. We did discuss that there are no real good protocols out there for cervical spine surgeries. You take it, ACLs for example, there are protocols for every single type of ACL surgery, different types of protocols for each ACL surgery, and it's just incredible to me. The key to following a protocol though is to use it as a guide. Now there are variations in every patient's recovery. Okay, they may have had a rotator cuff and they're diabetic and they have a thyroid problem. They are going to be more apt to stiffen up than other patients. So if you proceed slowly with a protocol in a situation like that, you may get stuck in a situation where they end up with an adhesive capsulitis. So you have to really pivot often while you're utilizing this guide of a protocol to kind of work around that. So what I'm going to do today is I'm going to bring you some experience on what I have seen, what works best. I've done some research on this and really, to be honest with you, it's kind of vague out there on what helps the best. So let's just talk a little bit about that and about post-op ACDF patients and how we manage them and what works the best. Now, some studies out there show that there have been no differences between doing PT or just leaving the patient alone after an ACDF surgery. I can't say that I completely concur with that. I think that, I've seen a lot of patients who have had this surgery. Some come out and they're almost completely pain-free. I've had people leave surgery, come here the next day and give me a hug and a kiss on the cheek and say, thank you so much for sending me for that surgery. It's the first time I'm pain-free in several months. I feel so much better now than I ever did. And those folks do really, really well. But there are some people that don't, and it could linger. The pain could linger. The associated surgical discomfort can go on for several months after surgery. And so those are the folks that we really need to kind of guide and help along. There are so many factors in regards to how a patient will do afterwards. One could be their age. Were they a smoker or non-smoker? Is there some sort of an overlapping chronic myofascial pain syndrome? People have this discomfort. They might have instability, spondylosis. And that will cause them this chronic discomfort that they have in their neck with a lot of tightness. They're not moving it very well. So they could end up with some sustained postural stress. Maybe they've had multiple levels of instability, osteoporosis, which is a contributing factor in regards to how they fixate the fusion when they do it. Maybe the patient is overweight and that it makes the access to the neck a little bit more difficult for the surgeons. And maybe they've had a previous ACDF, but there are so many factors and the list goes on why they may have some difficulties after this surgery. So this is how I approach ACDF patients. Usually it's, hi, how's it going? My name is Paul. I'm a physical therapist. I'm going to help you today. But no, not to be too funny here. But I like to see them around 4 weeks. Sometimes earlier, if they're having like a lot of discomfort and they need to get that pain under control. In a situation where we live, the neurosurgeons are 3 to 6 hours away. And so to get there for, oh, let's run into the office and get checked out is not so easy. So we do a lot of, assisting for them. So if a patient has a lot of discomfort, we may check them out. First thing we want to do at that 4-weekish mark is, recognize, are there any red flags here? Is there any redness around the incision, near the throat? Is there any drainage? Is it swollen? Do they have a fever? Maybe they have some sort of a speech impairment. That is something that you need to kind of keep an eye on. It's not uncommon to have that. They generally get better over time in regards to their speech. But if it progressively gets worse, you need to contact the neurosurgeon or their group and say, these are the things that we're finding. Something just doesn't quite look right here. Here is where I do a lot of education with the patients. I will teach them, the do's and the don'ts. And unfortunately, I see a lot of patients who are told this right after surgery. Watch out for the BLTs, bending, lifting, and twisting. And they use this same terminology and acronym for low back pain also. And I kid you not, and this happens a lot. A gentleman had neck surgery and they were driving home the next day after surgery. And he went to talk to his wife and turned his neck probably 10 degrees. And she said, oh my God, they said, don't bend, don't lift, don't twist. And then they lose their minds. And so what they do is they end up keeping this really, really stiff neck for 4, 6, 8, sometimes 12 weeks before they come to therapy. And they come in and they are having more discomfort because of myofascial stiffness and sustained postural stress than anything else. It's really not as much from the surgery, just out of the fear of damaging that tissue. So it's very important that you understand the surgical techniques and how this was done so that you know what you can do with the patient, what you can't do with the patient. So I tell them, don't stay in any one position for a long time. It's okay to look side to side. It's okay to look up and down. Just don't do it to the extreme. Let the discomfort kind of guide you a little bit, but do move. You want to try to get this normal moving neck pattern going. And so I tell people, don't hold it too stiff. If you're going to be on a device, put that device, what may be an iPad or maybe your cell phone or something like that, put it up on some pillows on your legs and get it up in front of you a little bit so that you're not looking down toward your belly or down on the device, so you're not in one position for a long period of time. I tell them not to undergo any high velocity manipulation or hard passive stretching. Some people have this need to go get a manipulation after this because they think that is going to fix their neck pain. Well, if this is post-operative neck pain, remember, we want fusion here. We don't want to disrupt that ability for it to fuse. So it's important that they kind of take it easy. We don't do any cervical traction early on at 4 weeks, 6 weeks, 8 weeks. If somebody comes in and they're 12 weeks and they're really tight and they're getting some compressive tight pain, I might do a little bit of suboccipital release and very gentle traction, but definitely not at the 4-week period. Again, we want that to fuse together. Then we're going to start activating the muscles affected by the nerve root compression. All right, so we're not really activating a lot of the neck muscles, but let's say somebody had significant C5 nerve root compression and they had deltoid weakness, bicep weakness, weakness into supination. We're going to start at that 4-week mark, starting to build that up a little bit, okay? We're going to do some light bicep curls, some light supination strength training activities, gentle isometrics with deltoids. If it's a C6, we're going to start to activate those wrist extensors. C7, we're going to turn on those triceps. But it's okay to do finger, hand, wrist, elbow activities with these folks early on to start to get them into a, to start to turn those muscles on again. Okay, now that that nerve root has been released and it can send better messages to those muscles, we want those muscles calling for that message so that they can start to activate those and not become too atrophied in this whole process. You want to start moving the traps to avoid myofascial pain because of this stagnant, sustained postural stress. They can get a lot of congestion in those muscles, and we know that people who don't move their traps a lot end up with chronic myofascial neck pain. So there's nothing wrong with getting them moving, doing some light shoulder shrugs, maybe some shoulder circles. I'm a big advocate of retracting the scapula and bringing them down and depressing them a little bit. There's some old research out there 30 years ago. I wish I could get my hands on it, but I remember them doing some EMG studies to the upper traps, and they seemed to relax the best when there was active scapular retraction and depression of the scapula at the same time. So activating the lower traps takes pressure off of the upper traps. So that is fine to start early on as long as you're doing it, nice and easy and progressively. If people like heat or ice, either is fine. Remember, the heat and ice are not going to penetrate any more than 2 centimeters down deep into that area. The surgery was done anteriorly, so you're not going to be putting heat over the incision or over the front of the throat. It's just not something you would do. Putting it over the back can help relax maybe those muscles that are in spasm. Some people may like, dry needling or something like that to help break down that tightness or those trigger points in the upper traps. But remember, the underlying cause of that discomfort that some people get in the back of the neck and in the upper back is because they've taken those vertebrae and they've stretched them apart. They basically lifted the house off the foundation, put a spacer in there, and they keep it like that. Well, in the process of expanding that, if somebody has had like degenerative disc disease and the vertebrae are really close to each other, then all of the surrounding ligaments, the facet capsules, and that posterior longitudinal ligament, that's all going to become shortened. And then the surgeon will stretch that out. Well, by doing a lot of that stretching, that can really activate some of those nerve fibers back there and cause that deep posterior cervical spine and upper thoracic pain. And so we have an underlying problem that is causing this. So treating the surface is not always the best thing to do for a patient, but if they get some comfort from that, that is perfectly fine. That is all safe to do as far as heating and icing goes. I tell these people, get to walking, okay? Start a walking program, increase your distance, because what happens is while they are walking and swinging those arms, they're getting this nice, gentle, rhythmic motion of the neck, and that is helping to settle down that pain that they're having. It helps to decrease that stiffness in the neck, and it's all very indirect, passive motion. So I'm huge on doing some walking with patients after surgery, right after surgery. I mean, even before 4 weeks. You want to have them avoid heavy carrying, okay? We don't want to load those upper traps too much because remember, the upper traps have this compression type of activation on the spine. So as the upper traps contract, it pulls the head down toward the spine and it really compresses them. So I try to avoid anything that really fires up those upper traps with a lot of resistance. So active movement is fine, like shoulder shrugs, but don't do shoulder shrugs with 20 pounds is what I'm trying to say. So next kind of time frame we're going to look at is that 6 to 8 week time frame where we're looking at starting to implement more postural retraining. So doing things like prone T's and Y's while the neck is in a nice neutral position, the head is rested. They might also do some seated rows, activating the rhomboids, but with the palms down on the bar and the elbows out, squeezing the rhomboids a little bit more and not doing so much of a seated row with the palms up with the elbows. So you're not activating those lats and those upper traps as much. I also like to get these folks into pec minor stretching, so maybe a thoracic pivot at the mid-thoracic spine with a pillow doubled up back there so their spine is nice and neutral, but getting that thoracic spine to extend a little bit, we know that if we can do that, the cervical spine isn't going to have to work so hard at each segment. I then will progress these people into some deep cervical activation. I like to start them just on a table with my hand behind their neck, or they might even have a blood pressure cuff, and they're just activating the deep cervical muscles, trying to rest the sternocleidomastoids and just getting those to turn on a little bit. I'm a big advocate of the upper body ergometer because number one, it increases blood flow to the body. It helps to passively get the neck and upper body moving a little bit. So lots of good blood flow to the arms. And then you get this little sliding and gliding of the neural complex throughout the upper extremity. So you get this little, gentle neural mobility. I love doing that. I get them in a good, comfortable position and get that heart rate up there a little bit. Then we want to start working on some heavier resistance training to the affected myotomes. So we talked about that earlier, your biceps, your triceps, your supinator, pronator, your wrist extensors, your gripping muscles. all of those, we can start to get a little bit heavier as long as we are not getting crazy with stabilizing the neck with hard resistance activities, okay? So then I started to consider nerve gliding and sliding. I think that is very important. We all know that people get relief when they have a nerve root compression by doing what we call the shoulder abduction sign or the Bacodi sign, which is basically, flex the elbow, get the arm overhead, and it takes them out of this neural tension position. Well, if they're doing a lot of reaching pre-surgery, that reaching is going to cause a lot of neural tension, so they tend to not do that. Therefore, they start to lose this neural mobility, plus the nerve root is being compressed in the foramen and not able to slide and glide very well. So remember that, the surgery and the decompression of this nerve will cause some inflammation and swelling, so it can anger that nerve root a little bit. So you don't want to get crazy with nerve gliding and sliding, but it's definitely time to start doing that because it's time to start reaching a little bit. And when you start reaching, if you overstretch, you're going to aggravate that nerve. So sliding and gliding, nerve glides are going to be very important to progress into. Now, we want to also start some light manual techniques. I like soft tissue mobilization. If those upper traps are really tender, I like to get into the suboccipitals and do a little suboccipital release. Oftentimes they'll get so much spasm back there, they can get some suboccipital neuralgia, get some headaches associated with that. And I might even kind of flex them a little bit, open up those facets and get a nice little stretch. I'm not tractioning them hard. Maybe I'm pulling 5 to 10 pounds of pressure just to get that mobilized and moving a little bit better. At 8 to 12 weeks, if you need to continue with the patient, one of the things you want to do is, check out that scar, and you have to follow this scar along. If people come in and they've had a history of adhesive capsulitis, or maybe they've had Dupuytren's contractures or plantar fibromatosis, where they have a lot of fibrous buildup, they may scar down pretty hard at that incision on their neck. And I've seen people have really thick scar tissue there, and it affects their ability to swallow, their ability to speak. So you want to make sure that incision's closed up nicely, but then get into some scar tissue mobilization, even mobilizing the soft tissue and separating the skin from the platysma that is underneath there, and just manually mobilizing that and then getting them comfortable with it and starting to get that mobilized. I have a great picture, I know it was a couple years ago, of somebody who had a huge scar build up there. If I find it, I'm going to throw it into the pictures on the email that some of you will see and get. So try to check that out. If I can find it, I'm going to put that up for you. Now again, you're at the 8 to 12 week mark. Now some people don't even start physical therapy until then, which to me is not right, but I get it. I get it from the neurosurgical standpoint that, listen, I did this, $100,000 plus surgery. I did a lot of great work and, put everything back right where I want it. I do not want to disrupt that. I don't want to mess that up. But there are a lot of patients out there that really need a lot of guidance. And typically if they're coming in at 12 weeks because they're still having problems, they're going to be really stiff. They're going to have lost some proprioception. They're going to be having a lot of myofascial pain associated with this. So I really like to see them at that 4-week mark, if not a little bit earlier, unless they're having some trouble. So what I want to do now is I want to really start to assess that need for higher level ADLs. So maybe they've got children and they need to pick them up, or they need to move something around the house. Maybe they're trying to get back to work and they have to do a lot of lifting, pushing, pulling. Remember, 12 weeks is a decent time for some good healing of that fusion, and that's when we expect a majority of that fusion to happen. But they will continue to fuse and develop, some bony consolidation in there for up to 1.5 to 2 years after surgery. So you're doing really well at 12 weeks. Things are looking good. We can start to push ahead a little bit, but we still need to remember that there's still some fusion going on. So I now want to start to build up some of that cervical spine muscle endurance. Isometrics in both directions. We can start doing some sustained isometric holds, so you can put them prone with their head kind of off the edge of a table, have them lift it and hold it in a neutral position. Maybe they're laying on their side and they're holding that lateral position for some time. I might start with 15 seconds, build them up to 45 seconds to a minute of holding in that position. I might even start some resisted TheraBand exercises in each position, and then I'm really looking at actively increasing range of motion. So if they're a little stiff in their end range, I might have them actively rotate to both sides, laterally flex, but I don't do a lot of this hard aggressive stretching with them, okay? Interestingly enough, if somebody's had discomfort in their neck for a long time, maybe they've had a listhesis, maybe they have spinal stenosis, maybe they've had some central cord stenosis and they've had some myelopathy, and they've had this neck pain that's been there for several months, maybe a year or 2 years, and they've had all this discomfort. They go in and they have this ACDF done, and all of a sudden there's more space, the foramina are all opened up, the nerves are not angry anymore, and they actually come out with better motion right after the ACDF than they did before. And you would think that they would lose motion because they're stabilizing 1 or 2 segments, sometimes even more than that, 3 or 4 segments. But when they have that single level segment done, some people come out with better range of motion afterwards. So I don't really push that hard. They get this naturally when they're driving their car, looking up and down the street when they're at the stop sign, or maybe, you know, when they're sleeping at night and their neck is in a certain position, they're going to get some range of motion there. So I don't really ream on that, but I do work on getting it actively, and I make sure that we start to push in, you know, a lot heavier in regards to postural retraining. Now, don't forget adjacent level segment issues. You might want to consider a good thoracic spine mobility program like open books and thoracic pivot extensions, maybe some manual mobilization, PA mobilizations, and trying to improve that, you know, thoracic rotation will really take a load off the cervical spine. And you'll find those patients will do really well with that. So most ACDF patients I have seen do very, very well, okay? Now, a lot of it has to do with, you know, good surgery being done on these patients, choosing the right type of patient to do the surgery on. But I do have some advice. And the number one piece of advice I have for you is avoid complications. Know what the surgical procedure is. You know, go to YouTube, take a look at a couple videos, watch what happens there so that you see what's going on, and then you will feel much more comfortable treating ACDF patients. Like we look at them and we're like, you know, you feel like you're going to break the meatball off of a toothpick, you know, when these patients come in, and you know, it's really not like that. They're pretty well stabilized. They have this little plate on the front for most of them, and you know, and that keeps them pretty solid. They've got a spacer in there, and it usually comes along nicely. So avoid complications. Know what that surgical procedure is. Heck, get in and watch one if you can. Understand the healing time frames, that it is going to take some time. Now, if somebody has underlying comorbidities, maybe they're a smoker or they're obese and they don't exercise much and they don't have a healthy, you know, lifestyle, it may take them a little bit longer to heal. So that can take some time. If somebody's not showing, you know, great consolidation, they may require a bone growth stimulator, and that can be worn for several months and is pain-free and can help, you know, advance that healing. We do see that with some folks where there might be some question on their healing time frames. Listen to your patients, okay? A lot of them will come in and they'll say, yeah, you know, things are a little bit rough. I have a little hard time swallowing, and I'm getting this pain in the front of my throat, or I'm getting this pain in the back of my neck. Listen to them, you know, and assure them that, you know, it can take some time to heal, but you want to make sure that they're not developing some sort of complication. So listen, take a look at them, check them out. If you feel like something's not right, call the neurosurgical office. They'll be more than happy to kind of discuss with you or with the patient and take them in for a visit, or maybe even a telemedicine visit, and they'll check them out. I think the number one reason why we've had such good success with patients is that we've developed this great working relationship with the neurosurgical group and their staff, and we understand what they're looking for in a patient who needs to have an ACDF. And so we know that if we've exhausted conservative therapy and they're not getting better, maybe they're a good candidate. Or if we see some real neurological compromise and we see some progressive weakness and whatnot, we can recognize that and say, okay, this is a good ACDF candidate. But once you understand that and you see these patients, it gets a lot easier in regards to the rehab, and those folks generally do well. So last tip I have is educate your patients. The more they know, the more you know, the more they know, the more comfortable they are with you working with them and progressing them through a nice, steady rehabilitation after their ACDF surgery. So I hope you feel a little more comfortable, regarding the treatment of patients with ACDF. Hope you enjoyed today's podcast. Tell your friends and colleagues about us. We're going to continue talking about this. If you have questions, feel free to send them in. We've got a question-related podcast coming up next week, and we are excited about answering that and discussing how we're going to manage this particular patient situation. So again, thank you for listening to the Ortho Eval Pal podcast. I appreciate you. Be kind to each other and take care.